Okay, so my name is Kay Connelly, and I am the director of the Proactive Health Informatics Group here at IU. And our informatics group is a little bit different in that we are really looking at how can we design technologies for patients outside of the clinical setting so that they can better understand, manage, and improve their health. We don't do as much inside the clinical setting, and here are the other faculty who are in our group. What I'm going to talk about today is not so much a specific technology I've designed, but more a population that I'm really interested in working with, and that is low socioeconomic status populations. So the reason I'm interested in this is if you look at kind of our overall health as a country, you've seen that over the last several decades, we have increased longevity in terms of how long we're going to live, better health outcomes, better quality of life for most of us. But if you look at the poorest amongst us, this is not true. Either we've kind of stagnated or we've actually had declines in longevity. And so I'm really interested in how can we help this population, not only because I want to improve these numbers, but also if you look at kind of the healthcare utilization, you often see that a low-income population waits until they are so sick that treating them becomes much more expensive. So this can also help our overall healthcare system. So I've had over a dozen projects in the last decade, and I've learned a lot of lessons, and I kind of bend them according to these general categories. I'm going to try to just give you one lesson for category, just so you can have an idea of the kinds of things that I'm working with. So the first one has to do with access. I work in a lot of rural areas. There's a lot of low-income people in southern Indiana and rural areas, and we're so connected. We're used to being connected all the time. It's hard to imagine, but there are a lot of places in southern Indiana, these white areas, where they can't get broadband in their home. There are a lot of cell phone connectivity problems, not just the cell signals in these areas, but also a low-income population often has very intermittent cell cover or cell service because of they let their phones expire, they lose their phones, et cetera. And so the kinds of connectivity that you can rely on when you're designing these technologies is really spotty and very population dependent. So it's something that you have to think about as a technologist. Another really critical issues you have to think about in terms of the design space is their abilities with literacy and numeracy. Even though the US publishes literacy rates over 90%, you have almost a quarter of people who do not have functional literacy. That means being able to take things that are written and actually apply them in their everyday life. And almost a third of people don't have adequate numeracy skills to do something like read a nutrition label and understand what it means. And so we have to take these into account. We can't just go get a mobile app off the App Store because most of those require high levels of literacy and numeracy. There are a lot of interesting methodological challenges working with this population. One is kind of good. They love getting technology and they love showing it off to their peers, and that's really fantastic. That can help with the adoption, but it also can really complicate data cleaning. I was doing a study once where they were scanning barcodes for things that they were eating, and we were looking at these sessions, and sometimes we'd have these sessions of like 20 things that were scanned all in one sitting, and it included things like dish soap and paper towels, and we knew they weren't eating those things. And so we have to be really careful about what data is actually real that they're recording and what is it that they're showing it off to other people. In terms of privacy, there are a lot of interesting issues here. The one I'm going to highlight here is we all kind of fib to our health providers, how many alcoholic drinks do you have a month, those kinds of things. And I think it's a little bit more interesting and severe with this population because the power imbalance between a low-income population and their providers is very different. And they often, this population often doesn't want to get chastised by their providers for doing something that maybe they know they're not supposed to do. So they may say that this is what they're eating, when in reality, this is what they're eating. And this is really important for when you're designing the technology because they don't want the technology to tattle on them. And so if you make it so the provider is going to see all of those details, they're going to lie to the technology, which also means they're lying to themselves. They're not getting the benefits of being able to reflect on their true behaviors. So you have to build in this ability to lie or at least to withhold information. There are a lot of ethical concerns as well. I put a few up here, but one of the biggest that I struggle with every day is if I give a technology to this population that really works, I can't leave it with them, right? Maybe I'm purchasing data plans for them, and my grant runs out. I can't purchase data plans for them anymore. I can't afford to maintain these applications over time. If it's a mobile app, maybe it'll work for a while, but those nutrition databases, they get expired, and all of a sudden you can't keep it up. And so this is a really big challenge when you're working with desperate populations who are benefiting from something you've developed, and all of a sudden you have to take it away. It's a hard thing to do. So with that, thank you.